My name's Georgina Long. I am from Melanoma Institute Australia in the University of Sydney, and on behalf of my co-investigators, I'm very proud to be able to present the results of Pembrolizumab combined with Ipilimumab for patients with advanced melanoma. These are the results of the KEYNOTE-029, a Phase 1b Expansion Cohort study. So the rationale for combining CTLA-4 and PD-1 or PD-L1 blockade in melanoma is well established. CTLA-4 blockade working at the priming phase or the periphery where antigens are presented to T cells, and PD-1, PD-L1 blockade working at the effector phase right at the tumour bed, blocking T cell inhibition of cancer cells. We know Pembrolizumab and Nivolumab, anti-PD-1 therapy, significantly improve outcomes for patients with advanced melanoma over Ipilimumab. We also know that the combination of Nivolumab at 1 milligram per kilogram combined with Ipilimumab at its standard dose of 3 milligrams per kilogram significantly improves outcomes for patients over Ipilimumab. So for this study, KEYNOTE-029, we explored whether a lower dose of Ipilimumab, 1 milligram per kilogram, combined with Pembrolizumab at full dose, would be efficacious but with significantly less toxicity than what we have observed in the previous combinations. So with the study design, there was a dose run-in where the dose of Pembrolizumab, standard dose 2 milligrams per kilogram, given every 3 weeks, combined with Ipilimumab, 1 milligram per kilogram, given every 3 weeks for 4 doses, was explored in patients with advanced melanoma or advanced renal cell carcinoma. Based on these patients, it was decided whether the combination was tolerable due to the dose-limiting toxicity rate. If it was tolerable, we continued to the current study, and that's what I will be presenting today, the dose expansion in Part 1b. If it was intolerable, of course, the development would be stopped. During this run-in phase, the combination was very tolerable based on the dose-limiting toxicity rate and the adverse event profile. So I'm presenting Part 1b, which is a study of 153 patients who were enrolled and treated with the combination of Pembrolizumab at 2 milligrams per kilogram every 3 weeks and Ipilimumab at 1 milligram per kilogram every 3 weeks for 4 doses. 110 patients, at 72%, received all 4 doses. 86 patients, 56%, were ongoing at time of data cutoff, which was March the 17th, 2016. This is a median follow-up of 12 months and a minimum follow-up of 6 months. 67 or 44% of patients had discontinued at data cut, and the reasons for discontinuation are shown there. You'll note that disease progression occurred in only 29 patients, which is less than half of those that had discontinued. Adverse events resulted in discontinuation in 31 patients. The baseline characteristics of patients shown here, they are not very different from previous studies in advanced melanoma, except that you will note that those with elevated LDH comprised 24% of the study population. And consistent with previous programs of Pembrolizumab in melanoma, 83% of patients were PD-L1 positive using the Merck assay. The majority of patients had not received a prior treatment and were, in fact, treatment naive. Shown in the next slide here is a summary of adverse events for this study. You'll see on the left column treatment-related adverse events, on the right column immune-mediated adverse events. Any grade treatment-related adverse events occurred in 95% of patients, grade 3-4 in 42% of patients, immune-mediated 58% of patients for any grade, and 25% of patients had immune-mediated adverse events of grade 3-4. There were no deaths in this study due to therapy. In terms of discontinuation, 10% of patients discontinued Ipilimumab only, 7% discontinued Pembrolizumab only, and 10% discontinued both Ipilimumab and Pembrolizumab. A proportion of those, over half of each of those, were due to immune-mediated adverse events. So the next slide here shows the incidence of immune-mediated adverse events. Just to remind you, immune-mediated adverse events, 58% of any grade of patients had any grade, and 25% of patients had grade 3-4. The most common were thyroid disorders, hypothyroidism, hyperthyroidism, as well as other endocrinopathies, hypophysitis. You'll notice the rate of colitis is less than 10%. On this slide, grade 1-2 is in blue and yellow is grade 3-4. For the next slide, shown here are the immune-mediated adverse events, the resolution and the treatment, but instead of by patient, this is done by total events. So on the left, 57% of events required treatment with corticosteroids, 7% infliximab, and 4% other immunosuppressants. And if we look in terms of the events that had resolved, 76% of any grade event had resolved at data cut, and of 81% of grade 3-4 events had resolved at data cut. The next slide shows the RECIST response in this cohort. The overall response rate was 57%. The disease control rate was 78%. And you'll notice the complete response rate with this median follow-up of 10 months was 10%. More importantly, 98% of responders were still in response at time of data cut. This next slide shows a waterfall plot. You'll notice 81% of patients, that's the inflection point on this waterfall plot, had some tumour reduction with a median change of 54.5% in their tumour size from baseline. The PD-L1 positive patients are shown in yellow, the PD-L1 negative is shown in blue, and you'll know that both yellow and blue stretch across either side of the inflection point, meaning PD-L1 negative patients do respond to this regimen. For the final slide, shown here is the Kaplan-Meier progression-free survival, demonstrating a 70% progression-free rate at 6 months. This is 49 events, or 32% of events, and the median progression-free survival has not yet been reached. So to conclude, the combination of pembrolizumab at standard dose, 2 milligrams per kilogram, combined with ipilimumab at a lower dose, 1 milligram per kilogram, appears tolerable. 72% of all patients received all 4 doses of ipilimumab. There were no treatment-related deaths, and there were 25% grade 3-4 immune-mediated adverse events. The combination had a robust anti-tumour activity with an overall response rate of 57%. 98% of responders remained in response at time of data cut, and the overall response was similar across key subgroups. 70% of patients were progression-free at 6 months. I'd like to acknowledge the patients and their families, the investigators and site personnel, and I'd also like to thank you for listening.